Moving on to headaches. A 32-year-old female presents for left-sided headaches. The headache was preceded by a series of flashing lights in her left visual field that developed over the course of 15 minutes and lasted 45 minutes. She reports nausea, photophobia, and phonophobia. What medication treatment is most appropriate for her symptoms? Intravenous lorazepam, intravenous methylprednisolone, sumatriptan 100 milligrams by mouth or 6 milligrams subcutaneous, inhaled oxygen, or butalbital oxygen combination. Of these available options, this patient is showing evidence of a migraine headache, and of the available options, sumatriptan is the best or most appropriate option. This patient's symptoms are typical for migraine with aura. The patient reports a visual field followed by headache, nausea, photophobia, and phonophobia. An occipital lobe seizure is possible. They are rare, and they usually don't have photophobia or phonophobia, nausea, headache. So lorazepam would be appropriate for a seizure, but her symptoms are much more consistent with migraine. Methylprednisolone could be appropriate for multiple sclerosis. The patient could present with visual field loss or visual dysfunction, but none of these other features are consistent with an optic neuritis or other MS symptom. We'll discuss cluster headaches. Her symptoms are not characteristic for it. And in general, try to avoid butalbital-containing agents. There's a list of 5 things neurologists should not do, and on that list is prescribing butalbital-containing agents to patients. Migraine headaches are characterized usually by the presence of a unilateral headache, photophobia and phonophobia, as well as nausea. Common misperception is that severity determines the migraine. It does not. It's the other clinical features. And the ones to really ask for are, do you have problems with light sensitivity, sound sensitivity, and nausea, which almost all migraineurs will say that they do. Tension-type headaches are usually holocephalic, and they can have photophobia or phonophobia, but rarely have both, which the migraineurs will have. No testing is required for migraine headaches. Imaging is sometimes obtained, but is not required. In terms of treatment, the front line or first line of treatment for abortion of a migraine is a triptan therapy or a simple non-steroidal anti-inflammatory. There are multiple options for prophylactic therapy if the headaches are frequent enough and severe enough to require treatment. Prognosis: most patients will have headaches recurring throughout life, typically from menarche to menopause. They tend to diminish later in life, and the development of migraines late in life is unusual, and that would be an indication potentially for imaging. Once you contrast migraine headaches with cluster headaches, a 47-year-old with history of chronic alcohol and tobacco use presents for severe boring pain in the left eye. Pain is described as excruciating. The patient was initially seen in the local ER where brain and vessel imaging was normal. What treatment option can be recommended? IV lorazepam, intravenous methylprednisolone, sumatriptan, inhaled oxygen, or butalbital oxygen combination. Of these options, this patient's symptoms are very consistent with cluster, and inhaled oxygen is one of the best treatment options. Cluster headaches are some of the most severe headaches. Patients will typically present with incredibly excruciating pain, and they seem to respond reasonably well at times to oxygen therapy. Lorazepam and methylprednisolone would not be indicated. This is not evidence of a seizure. There's not evidence of an inflammatory condition. Oral triptans, the onset is too slow, and they will not be helpful for acute attacks. By the time the medication works, the headache is resolved. And again, butalbital-containing agents should be avoided, particularly on a test. It will never be the correct indication on the test. Cluster headaches are severe unilateral headaches. They develop over several minutes, and they last 30 minutes to about 3 hours. No testing is required. That simple history is enough. In terms of treatment, acutely oxygen at 8 to 12 milliliters per minute is a treatment. Injectable sumatriptan is an option. And the oral therapies are too slow and will not help the headache. For prophylactic therapy, verapamil is commonly used, and recently approved agents, which are CGRPs, monoclonal antibodies, are approved for the treatment of cluster headache. In terms of epidemiology, this case would be the typical case of a patient with cluster. It's typically males at an overwhelming rate of about 5 to 1, usually in their 40s, and oftentimes with a strong history of alcohol and tobacco use. Symptoms classically occur in the evening. These can occur throughout life, again, are excruciating headaches that patients will present with.